Welcome and thank you for joining us today to hear from experts at Prisma Health on an important health topic. We're here today to discuss the new medications being used for treating not only type 2 diabetes, but are seeing a good bit of success in weight loss that we're hearing news reports on. My name is Rebecca Munnerlin. I'm with Prisma Health Media Relations. And today we welcome Dr. Yemi Olatunde, an internal medicine and obesity medicine specialist at Prisma Health in Columbia. And we welcome Dr. Sandra Weber, a Prisma Health endocrinologist and diabetes specialist based in Greenville. They will help us understand how these medicines work and how they are used, as well as the risks and what may be on the horizon for helping patients struggling with obesity and chronic health conditions. So we'll get right into it. I'll start with, first, let's talk a little bit about how this drug type works. Dr. Weber, can you give us a basic overview and how this helps your patients with type 2 diabetes?
Well, first, I'd like to say it isn't a new medication. We've actually had it around for over a decade. It's a class of medication called glucagon-like peptide 1 agonists, which means it stimulates the glucagon-like peptide 1, or which you'll hear referred to all the time as GLP-1, and it really triggers that receptor, which is part of how the gut communicates back to the brain, to the pancreas, to the liver, and how you actually deal with food, that food is coming in, and how to actually deal with it correctly. So it's actually a normal part of your gut hormones that are made that allows for communications to other parts of the gut, to the brain, to the liver. And so it is a very effective tool to deal with all phases of insulin resistance, including prediabetes, people who have insulin resistance for all reasons, as well as diabetes.
Thank you so much for giving us that overview. My understanding is that the two predominant forms of this drug are semaglutide and tirzepatide. And when they are being used for weight loss, is it used the same way as being used for type 2 diabetes patients? And are patients prescribed the medicines as a short-term treatment or a long-term, perhaps even lifelong treatment? This question to Dr. Olatunde.
Hi, everybody. Yeah, so as Dr. Weber has said, GLP-1s have been in the market for a while, up to a decade. And we also have liraglutide, also marketed as Saxenda for weight loss. And we have it marketed as Victoza for diabetes. So pretty much they work in the same way to help, your body get your metabolism for your blood sugar. They have receptors in the brain that actually controls your appetite, your craving for food. And they also work in the guts to actually make you feel fuller easily, which is how they help to sustain weight loss. So in addition to controlling your blood sugar for patients with type 2 diabetes, because they have this effect of controlling your appetite in your brain and also decreasing the amount of food your gut actually moves along, they help to achieve weight loss that way. While these medications are pretty much the same names, they have different doses. So for the liraglutide, the maximum dose for the Victoza is 1.8. But to achieve weight loss, it goes up to 3.0 milligrams once a day. The semaglutide and the tirzepatide are longer acting. So the semaglutide is marketed as Ozempic for diabetes, and for Wegovy as for weight loss. For diabetes, it goes up to 2 milligrams, whereas for weight loss, we need a higher dose of 2.4 milligrams. The tirzepatide marketed as Mounjaro for type 2 diabetes is now marketed as Zepbound for weight loss, and they have both the same doses. These medications are supposed to be used on a long-term basis because like type 2 diabetes, hypertension, any other chronic medical problem, obesity is a chronic medical problem and should be treated as such. So anytime we stop medications for blood pressure, we find out that the blood pressure starts to increase. So if we stop medications for weight loss, the weight regain is a potential effect.
Thank you. Dr. Weber, is it generally well tolerated for either usage? And can you talk a little bit about the risks associated with these medicines?
So yes, it is predominantly well tolerated. And again, as time has gone on, we have had over a decade of experience with these medications. We know that the first doses are usually the most difficult. So maybe a little different than some of the other medications that people are used to taking. And that is because of that communication back to the brain that says, are you full? Do you need to keep eating? Can you stop eating? That initial trigger is not been seen in these levels for very long. So those initial doses are going to be the ones that usually have the greatest impact. And you can sometimes see nausea and vomiting develop with those initial doses. For most people, it's going to be usually the first 2 doses, and then each one after that, it gets better. And you tend to have what's called the receptors actually respond because they had not seen this medication or not to these levels. So when you start any of these medications, you start actually at a very low dose, whether that was, and I'll use the brand names, whether it was Byetta or Victoza or Ozempic or Trulicity or Mounjaro, you'll see the same patterns with all of them, which is we start out at a very low dose so that we actually don't overstimulate those receptors in the brain, which is what usually leads to the side effects, the nausea, the vomiting. And those are usually, like I said, with the earliest and first 2 doses. After that, every titration you go up is going to typically be easier than those first 2 injections. And most people have very little problems with titrating up to the maximum doses. And most of these medicines, we are not trying to improve the weight loss, improve the insulin resistance, improve the functionality to the least amount. We're usually trying to get it to the best effect. So most of these medicines, we really are trying to start at the lowest dose and get them to the highest tolerable dose and go all the way to the maximal dose. Now, some of the other side effects that we usually see at the higher end are going to be slowing, as was mentioned, how the gut proceeds for getting everything from the mouth to the anus is a really concerted effort of how it goes from the mouth to the stomach, mixes to the intestine, through the intestine, and taking out the nutrients that are needed to be absorbed for the body to function. But all of that is a continuum. And part of what gets affected by these medications is that whole continuum can be slower. And so you can see problems across that whole continuum. Some people have worsening of the stomach emptying, and so can have more indigestion, have more retained foods or products in the stomach area that takes longer to process and move into the intestine. And many people also feel that they develop some constipation. So those are things to be looking for. And we do see that being worse at the higher dose, and what can sometimes limit how high or if you can get to truly the maximal dose.
That makes sense. Dr. Weber, this follow-up question for you too. Since demand seems to be increasing for these medications, and as you mentioned, thank you, that the medications have been around for a while, but it seems like they are very much a topic of conversation now, and more folks are seeking them. Are your patients, are your diabetic patients having difficulty getting the drugs, and have the shortages alleviated at all? If there have been any, do you see this improving?
Oh, what a loaded question. So I would say the reason why you're seeing this becoming so popular is as these medications have come out and evolved, you are seeing they're getting more potent and more successful with weight loss. With each generation that's come out, we are typically seeing a little bit more improvement in glucose control, but really significantly more improvement in the weight loss aspects, which is what's made them so much more popular now. And the ease of use. Taking something initially twice a day as an injection was a lot of work. Taking something now once a week is very easy. And put on there the benefit of it not having a risk of hypoglycemia. Now you've opened this up to a whole population that would be an ideal candidate. Those that you don't want to see a risk of hypoglycemia, but still see excellent glucose control and weight loss with ease of administration. Think of your nursing homes, your groupings where you have family trying to help out relatives. If you can do something that's an injection only once a week, that's a lot easier. So there's a lot of things that have become much more beneficial with the potency and the effectiveness on all aspects, as well as the ease of use, which has made them so much more popular. And yes, we struggle as a population with having higher rates of obesity, as take our community of Greenville, the upstate South Carolina, the South in general, the United States, the world, whichever population we want to look at, we are seeing more and more issues with weight. So having medications that can help with weight loss at the same time, either directly or through someone who already has diabetes or any of the aspects leading up to it, is extremely helpful. So all of those have led to an increased demand. And with that, we are seeing horrible shortages. And these are not medications that you want interrupted. So with more demand and more use, and really probably reaffirmation with the successes that everyone is seeing, you have word of mouth that this is working and helping me dramatically. I don't think you can go to a workplace anymore where someone hasn't said, why are you doing so much better? And then it feeds forward. So we are having still problems. It seems like it's a shift. When one runs out, everyone shifts to the other, and then that runs out, and then you shift to the other, and that one runs out. And then really on top of that, we really don't set our patients up for success right now. If you have an insurance plan that's covering it, they will cover one of them. They will require a prior authorization, and then their insurance, typically their care plan, runs out. And instead of saying, here's an alternative, the problem becomes, well, this is our approved one, but we're not going to get it for a month. Oh, well. And then you are left in a dilemma of what do? We don't want to interrupt therapy because then you actually develop the side effects again. So if you try to go to a different option that is available, well, now it's not on the formulary, or you have to get another prior authorization, or they'll have to have a higher copay. It just is set up to be not successful for the patient right now. And that's led to great problems, interruptions, increased side effects again, because they have to start again over. If you have to go over again, we start at a lower dose. Those are new prescriptions that have to be filled. It's just been fraught with a path that is making it very challenging for patients and making it really a dilemma.
Well, with hopes that we see some of these problems resolved hopefully in the near future, that's a good opening into asking Dr. Olatunde if you foresee these GLP-1 medications being prescribed to patients who are pre-diabetic or high risk for type 2 diabetes in the future. I know right now they may not be eligible, but do you see use of this medication heading that direction as a preventive?
Yes, absolutely. I think our society should be more focused on preventing these chronic medical problems, especially as they are very like the precursor to heart attack, to strokes, to amputations, to chronic medical problems, chronic dialysis need for transplants, liver transplants, need for kidney transplant. There is a myriad of medical problems that can be prevented when we treat the root cause, which is obesity. So I think it's very, very important that we start using effective medications to treat pre-diabetes or patients that are prone to having type 2 diabetes, so we can prevent all these health problems. And apart from the fact that they prevent type 2 diabetes, they also prevent, cholesterol problems. The studies that have been shown on all these GLP-1s or the GIP and GLP-1s have shown that they also decrease blood pressure, they decrease the bad cholesterol, they increase the good cholesterol. So there's so much health benefits from getting these medications approved for patients that have either prediabetes or any other medical problems.
As a follow-up to that, Dr. Olatunde, are your patients asking for this treatment specifically because they're aware of the potential weight loss benefit?
I think the social media has made those medications quite popular. And of course, patients come in with a preformed idea that I want to be on this shot, is working so much for my friend or my neighbor lost 50 pounds on them. And so, yes, I do get patients that come in to ask for these medications to treat weight loss. But the good thing is that we do have them to treat diabetes, and we have the ones that are FDA approved also to treat weight loss. So we can, for patients that our insurance could cover, we can definitely give them to benefit from these shots as well.
Makes sense. Dr. Weber, I'm skipping around on our questions just a little bit, but I'm going to skip ahead to something I think you touched on a little bit, which is are physicians advocating for the insurance industry to cover medications that are specifically for treating obesity to make them more accessible as preventive medicine?
Yes, we feel that the better time to use these medications are not after you have developed diabetes, but actually where you are in that process of insulin resistance, which entails many other aspects. Patients with polycystic ovary syndrome, patients with fatty liver, all have been shown to really benefit from these medications at a much earlier point. These are studies that have already demonstrated that, but are still not approved for use and usually not covered. Even those who have had success with weight loss, where when they first came out, the coverage was actually much better. So we actually have another issue, which is where we've had people who have had outstanding success. I can think of one of my patients who had what's called non-alcoholic steatohepatitis, or NASH, who had an outstanding response, was able to lose over 40 pounds, triglycerides normalized, liver enzymes normalized. But since they did not have diabetes, they just had impaired fasting glucose at a level that was at about, I think it was somewhere in the 110s. They no longer qualified. And so over the course of the next year, even with proven benefit, they still were not able to get the medication. And slowly, since it is really a chronic illness that is being addressed, as we would expect, the weight went up, the triglycerides went up, the liver enzymes went up. And we can see it in studies, and we can see it in our patients, that these would be excellent candidates for being on these medications. It is, however, very costly, as everyone knows, and that's the balance part. There are being lines drawn in the sand of how do we limit this medication for both cost and for supply, and hopefully those lines will change as time goes on.
Thank you. Some of these medications, the earlier versions, certainly were being used off-label, even though some of them have been released under new brand names now, specifically for weight loss, and as you mentioned, are expensive. Dr. Olatunde, are there concerns about compounding pharmacies or online sources selling these treatments and even counterfeits of these treatments?
Yes, there's been a rise in demand, and I think some individuals or professionals online do benefit from giving patients these medications. I've had a couple of my patients also getting the GLP-1s from an online source, but we find that we can't verify the safety or the efficacy of this medication. So I discourage patients from seeking help online with somebody that just writes the medications. These medications are supposed to be used in conjunction with lifestyle modification, with good eating pattern, modifying their diets, and also including physical activity and routine exercises to help achieve the most effect. They're not just medications that you take without having lifestyle modification to them. And I discourage patients from seeking out drugs online or from sources that they can verify.
That makes sense. Dr. Olatunde, how do these drugs compare to some of the drugs previously prescribed for weight loss? I know that this particular class of drug has a lot of chat about it right now as they've gotten better. Are your patients seeing success with any of the earlier drugs that you all may have had in your toolkit? And are you still prescribing those?
Yes, yes. So the treatment and management of obesity is actually dealing with the root cause. So different patients have different reasons why they achieve the weight they are in. So if it's patients that deal with insatiable hunger, when they have eaten, they feel like they have to plan for the next couple of meals, or they can feel full easily, the GLP-1s will work for that because it helps them to feel full easily. But for patients that they have low energy, or they just lack motivation to make changes, or they just crave certain foods, and that's what makes them to gain all the weight. So some of our other pills that we use to help with craving or with motivation or to give energy, like the phentermine or Contrave, will be more effective. So the treatment is tailored to individual patients and the root cause of why they gain weight. Is not just a blanket that GLP-1s work. GLP-1s do work really well because they have the added advantage of targeting two systems. They work in the gut and they work in the brain, as opposed to some of the other pills. So that makes them a lot more effective. But there are some patients that have contraindications to this, and so they might be able to benefit from the pills, which are well studied, and they've been in the market for much longer, and if they don't have any contraindications, will be very effective for them.
Thank you for that. I want to get to a couple of we've asked our reporters to post some questions in the chat, so I want to make sure I get to a couple of those before we run out of time. I'm not sure which one of you would want to address this, but there's a question about a new drug called Maritide that's now in clinical trials. Are either of you familiar with that, and maybe could tell us a little bit about how it might be different from other medications that are being used currently?
I'm happy to tackle that. So as you've seen this whole class of medications evolve, we're seeing that initially it was just looking at glucagon-like peptide 1 agonists. As we mentioned, those were the early ones. And then we now have agents that have affecting two of the hormones. So both glucagon-like peptide 1 agonists and something called gastrointestinal peptide agonists. So the one that has the two agonists there is now Mounjaro or Zepbound, as Dr. Olatunde had already mentioned. The next generation, which is now in studies, is actually looking at both of those medications, plus having a monoclonal antibody so it even lasts longer and has a greater effect. And that's what you're seeing now being developed, is how can we do this even with a more or an easier regimen, something that is a once a month injectable as opposed to a once a week, and having the potency against both the glucagon-like peptide 1 receptor and the gastrointestinal peptide. And with each generation, we're getting more effectiveness, especially for the weight loss, but also some more effectiveness for the diabetes. So these are the next generations. There are several that are actually in testing right now. It's not just one. I think the one that I see in the chat box right now, which was mentioned, which is actually Maritide, is the one that was it has the monoclonal antibody and is a once a month injectable. And so that too, I think, is going to have a lot of stir into this because it becomes easier and more effective. Those are two components to things that are what we would all like to see the whole that category of medicine go to, and hopefully less side effects as well, but that's what's in testing right now.
Got it. In regard to the shortages that are affecting patients who've been taking this medication for diabetes, what happens when they have to stop this medication unexpectedly or have to switch to another variety? Is that something that you're seeing some of your patients struggle with?
I can,
Yeah,
I'll
go ahead,
answer that happily. certainly we have seen that has been an absolute frustration. It was not designed that you switch from one medicine to the other, but out of necessity, we have done a lot of that, more than we would ever have liked to. And we have found that patients have actually found it quite tolerable to switch from any of 3 or 4 different of the GLP-1 agonists or the GLP-GIP agonists. And we haven't had so far, because it's not been on label. No one has studied switching from one to the other and back and forth and up and down dosages based on supply and demand, which has been very limited. So this is all trying to make a system work that was designed to be a smooth and a consistent system, which it has not been. But happily, we've been able to not have as large of a gaps by switching from one agent to another. And so far, that has been found to be very tolerable. Some people have had better effectiveness from one agent than the other, and more side effects or less side effects. So we certainly have been able to find out some individuals what is the most tolerable for them. And whether that adds up to what's going to be the one that's covered by their insurance plan or not doesn't always line up. And will not necessarily be the one that they'll be able to get from a costly or a cost-effective perspective for them, because like I said earlier, these are very costly agents and very hard to afford without insurance coverage. And as far as the gaps in coverage, those have been just absolute frustrations. And it puts patients on a roller coaster that they should not have to go through.
Thank you, Dr. Weber. I know you needed to jump right at 1, so thank you so much. Dr. Olatunde, I will go to you with the next question. Thanks again, Dr. Weber, if you need to jump off.
I do, and thank you for this opportunity.
We appreciate hearing from you. Dr. Olatunde, in terms of addressing of how folks are having to cope with the shortages right now, do you see a shift in healthcare guidelines to whom these medications are prescribed, potentially prioritizing some patients over others? And is there any influence by physicians that's being leveraged right now to try to get policies changed to make access easier and to somehow, mitigate these shortages?
Yes, so just like Dr. Weber mentioned, I also faced that, particularly with weight loss, when patients are no longer covered because of the cost of the medication, and the insurance, drops coverage for them. So this is a real big challenge, which I think, the policymakers, our insurance companies, people that, decide what kind of medications they cover or not, should definitely look into, because like I mentioned earlier, it's more important to prevent these medical problems, which eventually will lead to, productivity at work. If patients have this chronic medical problems and they have to be out of the workplace because of their medical problems, it will be much better if we prevented those comorbidities, rather than, letting them, get complicated such that they are debilitated or they die from them. So it's something that at my office we're looking into, to talk to insurance companies. I also talk to some drug companies and see how we can bring down the cost of these medications, because really, yeah, they are costly. But I think everybody should just work together, the drug companies and the insurance companies, to reach a middle point such that we don't have breakages in patients that are already started, and we have more access to patients that need to be on these medications. Patients that have type 2 diabetes or patients that have weight loss without type 2 diabetes, I don't think anyone deserves less care, because sometimes they don't have type 2 diabetes, but they have serious limitations to their movements, and their quality of life is so poor. They can't even walk without they can breathe well just walking a few steps. So these patients definitely do need help to lose weight, as well as patients that have type 2 diabetes. So what we've been trying to do, it's not been easy with trying to switch to other medications that insurance to cover or patients can afford. It's been really challenging, but we've been trying, and it's been a roller coaster for the past few months, I'll say.
One of the things I've read is that in some cases, it's not so much the medicine itself, but the delivery system, like the little injector that is in short supply. And we've been hearing about the possibility of some of these medications going into pill form, which seems, I would think, might potentially bring down the cost and make accessibility better. Do you see that on the horizon? Is that accurate based on what you're hearing from your drug representatives too?
Yes, I think some medications like the semaglutide is being studied at a higher dose that can take the place of like Ozempic or Wegovy.
In a pill form?
In a pill form, yeah. So a higher dose to treat for weight loss. So I think that definitely anything we can do to reduce the cost of these medications will go a long way to improve access.
That makes sense. Well, it sounds like you all are working with the folks in the industry that you have contact with, and they're certainly hearing from patients, I think, and I know there are patient advocacy groups. All of those, are those all playing a role, you think, in where these medications will go in the near future?
Yes, it will play a big role in where the medications go. Yeah.
I don't see any more questions in the chat, so I think we are good. I appreciate you staying over with us a few extra minutes, Dr. Olatunde. Thanks again, and we appreciate our viewers on Facebook and our reporters who have been with us today. Thank you so much, and we will see you next time with another important health topic from Prisma Health. Wishing everybody a great afternoon and a great week.
Thank you.